A 29-year-old patient presents to the ER for a severe bilateral arm stiffness for 3 days. 4 nights ago, the patient did their first ever high-intensity interval training class that included lifting tires and running down the sidewalk. ED vitals are normal, and labs are as follows. The UA has a spec grab of 1.015, 2 plus blood, but 0 RBCs per high-powered field. The CK is 18,000 units per ml, and the labs are notable for a potassium of 5, a creatinine of 2.8, and that's kind of it. So what is the patient not at risk for? Is it AKI, compartment syndrome, DIC, or is the patient at risk for all the above? So I'll give you 15 seconds to think about it. Try and commit to an answer. So the answer is D. The patient is at risk for all the above. So this patient has rhabdo. And if you have rhabdo, you are at risk for AKI, compartment syndrome, and DIC. So let's talk about rhabdo. So there are a couple of diagnostic criteria for rhabdo, and they're actually quite simple. You need an elevated CK and one of the following: an acute neuromuscular illness or a subjective change in urine color. So, very often we end up getting a CK, we have sort of an AKI, and the term rhabdo is swirling around in our heads. Notice that AKI isn't even part of this definition. You just need these things. So we are probably underdiagnosing rhabdo, which is okay because it's probably clinically resolving very quickly. So let's talk about myoglobinuria for a quick second here. Cells break down and they release myoglobin into the bloodstream, and myoglobin can end up leaking into your urine. So that's myoglobinuria. Dipsticks can be positive for blood because of myoglobin, but when you look under look with the microscope, there are no RBCs. And so it turns out that almost half of folks can clear myoglobinuria in the first 24 hours of rhabdo. So what does that mean for us? Well, if you have myoglobinuria, think of rhabdo. You don't have myoglobinuria, you still need to think of rhabdo if the rest of the story fits. So don't use this test for your rule in or rule out. And we do that very often when we're just screening the UA. So the history is really important here. Okay, so how does AKI actually fit into all of this? Well, CK correlates to the degree of rhabdo, but the CK itself does not cause AKI. This is actually a correlation. The heme pigment in myoglobin causes AKI. So the thought is that you have more release of heme pigment when you have rhabdo. So your CK also goes up, but it's the pigment itself that's causing an AKI. So the CK has to usually be greater than 15,000 if the rhabdo is going to cause an AKI. In the literature, if you look at what CK typically causes an AKI, it's kind of pretty wide range. I saw anywhere from 10,000 all the way to 15,000. So I picked 15,000 to be a little more conservative. What that does tell us, though, is that if the CK is around 800 or so and there's an AKI, it's probably not from the rhabdo and you need to go look for something else. So is there any way to predict if someone needs renal replacement therapy? Actually is. It's called the McMahon score. So I got a lot of variables: age, sex, initial creatinine, initial calcium, initial CK, the cause of the rhabdo, initial FOS, and initial bicarb. And so if you look at MD Calc, the branch point is at less than 6 or greater than or equal to 6. So if it's less than 6, the patient is low risk and usual care is fine. If it is 6 or higher, you actually need to initiate renal protective therapy, including high volume resuscitation. So there actually is a method to the madness of when to give patients fluid if they have rhabdo. That being said, if you give them a little fluid anyway, it will probably be okay. So to wrap things up very quickly, so this is all about the diagnosis of rhabdo. The diagnostic criteria, again, are an elevated CK greater than 5 times the upper limit of normal, and one of the following: acute neuromuscular illness or a subjective change in your urine color. Remember that an AKI tends to occur when the CK is greater than 15,000. It can definitely happen when it's less, but if it's in the hundreds, it is probably not the cause of the AKI. Myoglobinuria is actually absent in almost half of cases after 24 hours of onset of rhabdo. Our bodies just clear it really, really fast. Finally, we have the McMahon score, which estimates your risk of needing renal replacement therapy. And so if it's less than 6, you are low risk and you can use usual care. If it is greater than or equal to 6, that's high risk. And so you need high volume resuscitation to maintain a urine output at 1 to 2 cc's per kg per hour.